Nice, very nice presentations. I will now request Devasis to join as a panelist and Dr. Sunil Gupta to join in the program, and Dr. Ritesh Agrawal and Sunil Gupta and Devasis Das to moderate the session. Rajiv will be the panelist, Bansi, Jyotidev and Dr. Sunil Gupta.
We all are there, sir.
Yes,
waiting for.
Please.
Very good. Very good, Bansi. Thank you, Rajiv. Wonderful conduction. Thank you.
Thank you, sir.
Let us go to the questions now.
Yeah, Dr. Ritesh, you want to initiate or should I start?
Yeah, you should start, Dr. Devasis.
Okay. Now, is Dr. Jyotidev there? I think he's not there.
Questions, where is the questions are there? Any attendee put the question?
So, the first question to Dr. Bansi Sabu, he was the first. So, Dr. Bansi, there's always a confusion between a physician where to use a continuous glucose monitoring and where to use a flash glucose monitoring. What's your take as a clinician?
So CGM is a continuous glucose monitoring where you need a real time. Again, CGM is also intermittently scanned, which is what FGM, which is also very popular in our country. One of the reasons for it is becoming more popular, one, that it had come out with a software which I had shown that ambulatory glucose profile was much easier to interpret. But now with the Dexcom and other, they also started using the same software for the interpretation of the continuous glucose monitoring. But I normally advise the continuous glucose monitoring for those patients who are on insulin pump or multiple daily insulin injection. But what is more required for that, the patient should be empowered so much so that they can take care of these peaks also, because sometimes what happens when patients see their report continuously, suppose they had seen suddenly 80 and they may started feeling that I may go in hypoglycemia, and they may start taking something sweet or auto correction unnecessarily they are taking. That may be a problem also. So first I start normally the patients on a flash glucose monitoring, that too also pro. So they come after 5 or 7 days, and once we see, and once you have educated patient in that format, and now they are prepared to go for a continuous glucose monitoring, then we advise them for CGM. This is what in our clinical practice what we do. But internationally recommended is for type 1 diabetes, they are saying the CGM is the best. There should be continuous glucose monitoring. The flash glucose monitoring or intermittently scanned glucose monitoring can be for those to whom you are not using continuously, like every 3 monthly, because it gives you prediction for next 3 months. You can think of putting that type of device to them to intermittently monitor.
So if I ask you, Dr. Bansi, the leading question, I think nowadays they have a Libre personal version.
Yes.
Now, if a patient of yours is using, so how often do you tell him to scan? Because you have to scan every, so what's the frequency or how many times you recommend them to scan?
They are saying that it has to be, if it is less than 3, then it will not give you the report also. That's number one. The second is we have to tell the persons that, normally, which I tell them every 3 hourly, that is what minimum. Till not in the night time, but till last at bedtime and early in the morning, which they should do. If 11 p.m. they are sleeping, and early morning 7 o'clock or 6 o'clock, if they are getting up from that time to till late evening, every 3 hourly. And the second is also if they want to use the correction dose, the 3 hourly also, they can use this correction dose with a short acting insulin if they are on MDI or if they are on pump therapy also. So I tell them minimum 3 hourly, but if they can do more, then it is better, because more is always better to know about their glycemic excursion.
Yeah. Thank you, sir.
Ashish, I had a very practical question, very short question. Bansi and of course, Devashish, you can tell us, in our country, what is the take of CGM, FGM, connected meters, and SMBG?
What is take?
I mean, how much people have taken up the
sir, the maximum
CGM
using is the glucose meter, which is, if you see the number of glucose meters which are used by our patients, almost all type 1, they should have the glucose meter. That is what is minimum. And all type diabetic patients. Now, the point is, they are monitoring, are they monitoring frequently? Are they monitoring with the optimum frequency? Are they monitoring minimum 4 times or 3 times? That's a big major challenge for them. Now, regarding
And are they
continuous
connected? Connected? Are they not connected?
the
Are
connected
those meters
glucose
connected?
meter are too, because they are using, there are software apps which are available with some of the glucose meter which they can use with them, and they are not very frequently monitored, and they are not very frequently also connected.
Coming to FGM in type 2.
Type 2 diabetic patients
FGM use in type 2.
they are using very frequently. I think in most of the diabetologists and endocrinologists started using it, and maybe like any patient who is having hypoglycemia unawareness, to motivate him, to put him on the insulin, to change the therapy, to, for all these reasons, or to monitor the glycemic control also, we FGM. But again, the frequency is not like every 3 months or every 6 months. Again, it is used like once you had used, and then again maybe after 2 years you are using it. So it depends on that, very much individualized and very much different.
Sir, the major challenge in our country is, if you compare to the Western world, why they are using 90% of cases? Because it is reimbursed. If you put the Indian patients to US system, they will also use 90%. And if you take the US patients to India, they will also use like us. The major challenge comes
no, but
is
there is a slight clear difference as far as self-monitoring of blood glucose is concerned. Dr. Ashok Das is a chairman of CDIC, which is Changing Diabetes in Children, and where we were giving, now this year, since last 2 years, we are not giving them glucose strip, but we were giving them glucose strips like 100 per month. But many of our patients were not monitoring 3 or 4 times. Even these patients were given free glucose meter and free strips. Now RSSDA supported project also. So it is the prick which is also a major challenge. It's not just the cost of the glucose meter or a strip. It is the prick which is a major challenge. Major challenge is the education. We hardly educate the patients for monitoring. We don't have the dedicated diabetic educator who can educate them. And third, when they come back with that logbook, nobody is there to interpret it.
We don't look at it.
So that's a major challenge why they don't want to monitor it.
So I think the major challenge with the CGMS, what I feel, is also the interstitial monitoring by the sensor and the capillary monitoring. So whenever a sensor, I will ask to Devashish sir and to our panelists also, the closed loop system which gives data by the sensor to the monitor, to the machine, which gives the auto correction of the basal insulin. So what I learned, the interstitial fluid hypoglycemia will be sensed, and it will be 15 to 30 minutes later, we will give by the capillary glucometer. So how this gap will be managed? So and in fact, most of the time, our patient come to our clinic by sensing the freestyle Libra, where therefore, sir, it is showing 60-60 without symptom, the patient running to our clinic. So how to address this issue to our patient?
You have to understand one thing. You don't have to see when you're using, Dr. Bansi and Dr. Sunil and Dr. Raju will agree to me, when you're using a real-time CGM, you don't look for values, you look for trends. You look for the graph, where the sugar is moving, whether it's going 2 arrows up or going 2 arrows down. You don't look at the same, you don't look at the value. Value will be always different. When they are in stable state, the sensor glucose value and the blood glucose will be close by. But when they will be in hypoglycemic ranges or in hyperglycemic ranges, the difference can be 15 to 30 minutes or sometimes more. I do fully agree with that, because that's normal physiology. You can't change it. But when you ask about closed the loop systems, the algorithms have been made like that they understand that there is a lag in that, and the algorithms are working on that pattern only. Otherwise, with the data I showed you, they are real-time data. Real-time. They are not clinical trials. Patients in and out are using this data, and they are achieving a TIR of 82%, 75% with the same algorithm and with the sensor glucose being in the interstitial space and giving the sensing data to the algorithm.
You mean to say they are programmed, Devashish? They're programmed to take care of this. That is the answer he gives.
So, Devashish, if I could just add some comment to it, that we have one type 1 diabetic who just delivered a baby 3 months back, and on MDI she had a bad obstetric history 3 years back when we switched her to a pump, and she was on a sensor augmented pump. I think she was on 640G. And all through the 9 months and the 3 months before, she had a TIR which was almost 75 to 80% with hardly any hypo. So, she's a long-standing type 1, at least 15 years of type 1, 60 kilo lady using almost 80-85 units of insulin. But it is possible. It is possible to use technology to get the best TIR without hypoglycemia if you use the sensor continuously.
Yeah.
Now, affordability is a huge issue.
Yes.
And, because Medtronic doesn't have competition, the rates are very, very high, I would say. The day we get a good competition to Medtronic, I'm sure Debashish and everyone will have to cut the rates, because it is not affording to many people who will benefit with the pump. And that is the reality of the situation. If we could have affordable pumps, and if you had affordable CGM devices, a lot of type 1s, a lot of type 2s, a lot of elderlies would have really benefited as such.
I agree, sir. No, I agree. Whenever there is competition, always the benefit is for the customers.
Yes,
I agree.
Absolutely.
But you see, we sometime back did fight for the glucometer price to be down about 11, 12 years back. And the price did come down, Rajiv. It has really come down. We took out on it and all that. Can anything be done about this fear of FGM? I'm focusing on the type 2 1C. Can such a thing? We are talking about defeating diabetes. But for defeating diabetes, we need this. So can we have a price of the FGM? I don't know whether it can be cut down further, 1C.
Already in a very affordable price.
Yeah, it's about 2,300 here.
Now, affordability, as I agree with Rajiv, but again, what happens, it's a very relative term.
Absolutely.
For a multi-millionaire persons like Rajiv, maybe 2,000 may not be a very costly thing. But for a poor man like me, maybe a 2,000 may be very costly also.
Yeah.
So it is, it is very relative term. Yeah. But I actually feel that FGM, 2,400 rupees is the recent price of the MRP. Is quite affordable for 14 days continuous glucose monitoring.
Yeah.
In compared to Western world, I think it is at cost effective, but the Libre, which they have introduced at the 5,000 rupees, that sensor, is really relatively costly, because what we were having was only of 2,400, and now suddenly they increase the price of this Libre, which is almost 2 times. It is for their continuous glucose monitoring for the patients. That becomes little costlier, but still I think the Libre or Libre Pro is comparatively cost effective in compared to the Medtronic and Dexcom. Dexcom is very, very costly at present in our country.
Dr. Bansi and Dr. Gupta, one question, and even Dr. Das. The FGM becomes real time using GLIMP or the Ambrosia system. What is your opinion on that? Though it is not approved, can we as doctors tell our patients to use it as a part of treatment? Bansi, Dr. Gupta.
I do it. To be very frank.
I do it.
I mean, I have a patient with Ambrosia, and both we are using.
I know, but can we?
You and me both can talk, because we are not here giving any sponsored talk or support. So in NUCD, we can tell openly that yes, we are saying our patients to use Ambrosia, Glucon, Mayo. Yes. I mean, all these software, we are telling them to use it. And Jyoti Dev is the first man who told me to use this GLIMP, for your patients. So I'm sure Jyoti is here. So we started using it. For many of our patients, they are using this FGM as a continuous glucose monitoring.
I just had a question, Ritesh, to Sunil. How often have you used this CGM in the GDM and pregnancy? I talked to you yesterday about that most difficult patient I had. I told you yesterday. Have you used CGM and FGM extensively for the diabetes pregnancy or most GDM patients?
Sir, to be very honest, I have not used very aggressively, but because it is not being actually approved by even DCGI to be used in pregnancy, neither the AGP, at least in India. Recently, I feel they got approval for Pro in UK. That's what I am aware of. But in India, it was not approved. But still, off-label, we have used it in few number of patients. And just in some of the patients who are non-GDMs, normal pregnancies with the normal glucose OGTT, or GCT. We have used to just see how much is the, and we presented that data in some of the meeting, how much is the normal blood glucose in non-diabetic pregnancy, just to understand that what should be the target, what is being recommended for Indian populations. We have done it in around 7-8 patients, and we have come out with a good data which we presented it. So that is how we did it. In difficult cases, we have used.
Yes, Sunil. Yes, Sunil.
So we have used it in few of the type 1, 2 or 3 type 1 patients, and a few of them of GDM. Pre-gestational type 2 diabetes, again, we have used in few, but not very aggressively as per as CGM, this Pro is concerned. Libre, I am not using very often. Somehow I found it, I have done it in one of the non-diabetic person, and it found very erratic readings that time. But again, we have to possibly understand it more, and it is very costly, ultra costly. Vidarbha is a very poor state. It is not like Gujarat, which is really a rich state. But Vidarbha itself is a good, small place where people are not very, affording. It's not like Mumbai or Ahmedabad. But so we have to be little cautious, and it's very cost sensitive market here.
Rajiv, your experience in neuropathy?
In chronic kidney disease, you said?
Kidney disease, DKD.
FGM, actually, the indication comes very high whenever you have, hypoglycemia or hypoglycemia unawareness. And CKD seems to be right up there when we look at whether it's variability or nocturnal or fasting hypoglycemia. So whenever our patients develop hypoglycemia and repeated hypoglycemia and unawareness, we need to sense them to see how the sugar fluctuations occur. And chronic kidney disease is one place where there is going to be a lot of variability, because renal gluconeogenesis doesn't occur, and we all know how the fasting can drop in spite of very high sugars in the night. And that's where CGM will help in the management of patients. So I do use it a lot.
So we have used it in type 1 diabetes who had lipohypertrophy. And I feel that data you must have read it. It was in DTT, it got published. That lipohypertrophy, we put 7 days, the insulin has been taken at the lipo site and 7 days in the normal site. And it could really differentiate the GV in the first 7 days when the insulin was taken at the lipo site versus, and we have documented all Congo, MAGE, mean blood glucose, everything was statistically significantly lower when the insulin was taken in a normal site versus the lipohypertrophy site in type 1 diabetics. So we have done it in around 20 number of patients here.
Wow, nice.
Dr. Jayant, how much time we have?
We have no time.
It's already 5, yeah.
Okay. So
I don't want to disturb when Bansi is there, Sunil is there, Rajiv is there, Ashok sir is there. I don't want to disturb. But
so last question before I hand over to Dr. Ashok sir. Sir, last question, sir. To Dr. Rajiv. So what do you think? Which are the new technologies apart from what currently we're using, like CGM and insulin pump, which are going to revolutionize the way we are treating diabetes in times to come?
I think apart from what we are looking at in terms of glucose sensing, I think a lot in terms of catching complications early would be where technologies would come in. So you have today AI-based retinal evaluation. Today you also have AI-based foot evaluation. You have a lot of apps which are helping in nudging patients coming to a better control. I think these and a good integrated software along with that will go a long way. So again, I would like to end where I started off, that we are very late in adopting technology, and we have only looked at technology in therapy. We have looked at either sensing glucose or giving insulin, but there is a whole pool of comorbidity and complications and detection of early complications which is being missed. I think that's where technology actually needs to come in.
Debashish, can I just ask you one question about the maintenance or the cost of the therapy of this 780G?
Sir, I'm not very sure because I am not looking after India, so I'm looking at the Asia Pacific region. I'm not sure at what price they have launched in India. Whatever will be the price, you add if the cost of sensor, if you want to use it continuously, because the sensor works for 7 days. So for 30 days, you need at least 4 sensors. That would cost means around, I think, 3,000 rupees or 3,500 sensor cost. So 5 sensors per month. And apart from that, you have the consumables cost for the month, which is again around, I think, 5,000 rupees. And the cost of insulin. That would be the
insulin is okay, but it's around 20,000 rupees maintenance plus extra apart from the cost.
More than that, Sunil. At least 35 to 40,000 rupees per month.
Jayanti is looking at us. I think let us end this session. I have only one message to convey, which me, Jyoti, Bansi, all of us wrote. I think Rajiv, you were also one of the authors, where we said treating diabetes appropriately is cheap. So let the doctor decide if the technology there is necessary. It has to be used. That's my take on it, and I do that. And not treating appropriately, thinking that patient cannot afford. I think sure, but the Sunil has patients who can buy anything in the world. It is the affordability is a very heterogeneous thing. So not treating appropriately is costly. Thank you very much. And I think I hand over to Rajiv and Debashish to close the session with their comments, short comments.
So I think I will leave. We are already late. Dr. Rajiv, please.
I think fantastic session, and technology needs to be there at the forefront. Let us all have good technology and good usage and good uptake of technology to help patients. Thank you so much.
Thank you.